Okay, so you should be seeing a handout of like a skeleton thoracic cage, right? And what this is it's kind of a basic slide to show you how and why we auscultate a heart. Okay, so we're going to do heart and lung auscultation, and so we'll talk about it, and then we'll talk about blood pressure. Normally, this is something we would do like physically hands-on in class together, but we don't really have that opportunity, so we'll just do the best we can to talk about it academically. Okay, right here on your reading left, you'll see, hold on, let's see if there's a way I can, if I can write on this. Give me 1 second. I'm going to try to get into a format I can write on. Okay. All right. Can you all see my mouse kind of hovering over the thoracic picture there? If anybody wants to chat that in, if you can see my, not seeing it. Okay, rats, all right. Okay, all right, so auscultation of the heart simply means we're going to listen to heart sounds with a stethoscope. All right, so you can auscultate anything: lungs, heart, blood vessels, gastrointestinal sounds, okay, and so on. So there's, that's just simply taking the stethoscope, placing it over a body part, and listening. Okay, that's auscultating or auscultation of. Okay, in this case, we're going to be looking at the heart, and so where the mouse is, okay, this is the person's right side. Okay, so if you'll notice, now the things that I'm saying, you'll want to write this stuff down. Normally I would have tried to draw this out with you, but none of the ink stuff is working. So, divide this, so there's the sternum in the middle, okay? So what I'd like for you to do is just draw a straight line through the middle of the sternum, a straight line up and down through the middle of the sternum. So that way you know you're dealing with right and left. Okay, so on the right side of this person, you see the letter A. Okay, then we're going to go over to the left side and you see P, E, T, M. Okay, so here's a mnemonic thing for you. A, pet, monkey. A, P-E-T-M, a pet monkey. Okay, what these mean are the A stands for the aortic valve. Okay, so in other words, you're going to place the stethoscope on the patient's right chest at the second intercostal space. All right, so look at the mouse on your screen. Here's rib 1. Okay, So there's the clavicle. There's rib 1 that articulates with the manubrium. The space in between is called intercostal space number 1. So the fancy word for rib is costal. So there's costal number 1, intercostal space number 1, rib number 2 or costal number 2, and intercostal space number 2. So the reason why you want to put the stethoscope on the intercostal space is because it is easier to pick up on sounds, heart sounds, through like the soft tissue part and not bone or cartilage. So that's why you go into the space. Okay. So if you had a stethoscope and a person in front of you, you would place the diaphragm, and we'll talk about the diaphragm of the stethoscope later. So you have the diaphragm and the bell. Okay, you would place the diaphragm over the second intercostal space on the right, and that is, you're listening to the aortic valve. Okay, now that's not where the aortic valve is located, like physically located. That's just where you hear the sound the best. Okay, so second intercostal space on the right, aortic valve. Then you go over to the left side, second intercostal space on the left. That P stands for pulmonary valve. So you place your stethoscope there. Now, when you're first learning this, you're going to be palpating, okay? You don't really just eyeball it and place the stethoscope when you're first learning. Especially in a student clinical setting, the instructor wants to see you think out loud and palpate. So you're palpating the person's chest, and you're saying things like, there's the clavicle, there's rib 1, I'm palpating down, there's intercostal space 1, there's the second rib, there's the second intercostal space. I'm off the sternum, I'm in the space, I'm placing my stethoscope using the diaphragm, and I'm listening to, in this space, I'm listening to the pulmonary valve. Okay, then you go down to the third intercostal space on the left, and that E stands for Erb's point. Okay, Erb's point, which is right here, ERBS, Erb's point is where the S1 and S2 heart sounds are equal in pitch. Okay, Erb's point is where S1 and S2 heart sounds are equal in pitch. Okay, now if you're going, well, what the heck is S1 and what the heck is S2? Okay, here's the answer to that. The heart sounds kind of like this. It goes lub-dub, lub-dub, lub-dub. Okay, so there's a distinct S1 sound, which is the lub, and there's a distinct S2 sound, which is the dub. Okay, the S1 is a stronger sound. It's a little bit louder. The S2 is softer. It's not quite as loud. So therefore it's lub-dub, lub-dub, lub-dub. Okay, so that's S1 and S2. However, at Erb's point, they sound, they're basically equal in pitch. They sound the same. And you're going to pick up on that, the third intercostal space on the left. Okay, then you move down, move your stethoscope down to the fourth intercostal space on the left, and that is where you pick up on the tricuspid valve. So T is for tricuspid valve. Now that's not where the valve is physically located. That's just where you hear the sound of that valve. Fourth intercostal space on the left. Okay, now we're at the monkey part, a pet monkey. Now if you notice, the M is off-centered compared to the other ones, okay? So this one is fifth intercostal space, mid-clavicular line. Okay, the M stands for mitral, so this is where you listen to the mitral valve. And it is the fifth intercostal space, mid-clavicular line on the left. Okay, it's not physically where it's located, that's just where you hear the sound the best. Okay, so to recap, you would start on the patient's right side and second intercostal space on the right, aortic valve. Move over to the left, second intercostal space on the left, pulmonary valve. Work your way down, fourth intercostal space on the left, Erb's point, where S1 and S2 heart sounds are equal in pitch. Work your way down, fourth intercostal space on the left is the tricuspid valve sound. And then you move over fifth intercostal space on the left mid-clavicular line, that's the mitral valve. Okay, so if you ever have seen practitioners and whatever place the stethoscope over the person's chest to listen for heart sounds, it may look like they're randomly placing it, but they're not. Okay, it's very strategic locations and listening for the different valve sounds. Now, there are better stethoscopes out there than others. Okay, there's some good brands and some not so good brands. And this is one of those things, you do get what you pay for. I like the Littmans. Okay, I have a Littman Cardio 2 stethoscope. Okay, it's a nice one. It's not the best of the best, but it's pretty nice. Okay, so down the road, if you are in the market for wanting to buy a stethoscope and you're going to be using it for nursing, or you're going to be a PA, or hospital, whatever, it's worth getting a good one. Don't get a cheap one. Okay, and good ones start at about $125 and then they go up from there. They last forever. The patient's life is in your hands, so it's worth getting a good one. Okay. All right. So one of the abnormals that you might pick up on is a murmur. Okay. So they do grade murmurs in 6 different grades. A grade 1 is very faint, very mild, okay, sometimes very hard to pick up on, all the way to a grade 6 that's very loud, and you can pretty much hear it just by putting your ear close to the chest. I mean, it can be that loud. Okay, that would be a grade 6. All right, so grade 1 is the least of the murmurs. Grade 2, a little bit more obvious, where the murmur is heard. It's faint, but you still hear it. Grade 3 is moderately loud. Grade 4 is loud. Grade 5 is very loud. And grade 6 has a thrill over the heart. Okay, which is a so associated with the thrill means there's a vibration sense of the skin, like a type of turbulence. Okay, they don't have to have a thrill, it's just associated with a thrill, which thrill is a fancy word for turbulence or vibration, that you can feel, a sensation that you feel. Okay, we're not going to get into it right now. Down the road, you'll probably get into it in your clinicals, but there are more heart sounds than just S1 and S2 and murmurs. Okay, you have gallop heart sounds, you have S3 sounds, S4 sounds. Okay, that gets into the more advanced cardiology stuff. Okay, but what I want you to know is we do have an S1, S2 heart sound, and the different murmurs and the location of where you place the stethoscope on the patient and what valve you're listening to based on your location. Okay, over on your reading right there, you have auscultation of the lung. Okay, in a full comprehensive stethoscope lung exam, you're going to do the front chest and the back chest. Okay, so their posterior thorax and their anterior thorax. Now, in general, most clinics and all that, they take some shortcuts. Like, for example, if you are lying in a hospital bed on your back, so you're supine, and you've got a lot of tubes coming in and out of you and machines, you're hooked up to machines, and you're kind of knocked out because of the trauma, the medications, and so forth. They're really not going to flip you over to listen to your lung sounds on the posterior thorax. Okay, to listen to it on the anterior thorax. All right, so sometimes the clinical situation, it's inconvenient to place the stethoscope in one place or the other. So you work with what you have. And then there's some shortcuts and things like that that you'll learn in the real world. However, in a perfect, full auscultation lung exam, you do the front, okay, and look at all the different areas that you place the stethoscope, which we'll talk about in a second, and then you do the posterior, the thoracic wall as well. So that's a lot. Okay, and this patient is going to be hyperventilating because every time you take the stethoscope, place it on their body, they're supposed to take a deep breath in like this. And then you place it again. And they're going to do this 100 times and they're about to pass out, right? So there's a way to monitor that so that they don't feel faint, okay, because they're hyperventilating because of the way they're breathing, right? You can do it in intervals and so on. All right, so what we're about to go over is just the full thing, even though there's some shortcuts that you can take in an actual clinical setting. Okay, so the first thing to understand is the B, the BV, and the V. What the heck is all that? Well, the B stands for bronchial. Okay, so if it's a bronchial sound, that means it is a loud, harsh, high-pitched breath sound. It's the loudest of all the breath sounds. And really the only area that you find a bronchial sound, breath sound, is over the trachea in the throat area. Okay, so that's your windpipe. There's really not a lot of tissue between the windpipe and your stethoscope. And so you're going to pick up on a very harsh, loud breath sound. But they don't say it that way, they say bronchial. Okay, so you hear it right over the trachea, basically in that throat area. So you're off the sternum, off the manubrium, and the soft tissue of that throat area. Okay, Then as you move away from center, right, so look at the midline where the actual windpipe is. Once you start moving away from the center, so you're moving laterally, the next loudest is called BV, or bronchiovesicular. Bronchiovesicular. So that's a moderate intensity in breath sound. So you have loud, bronchial, kind of a medium sound, bronchiovesicular. And you hear it just lateral to the sternum on either side. Okay, and you're kind of over the primary and secondary bronchi there. So those are still large airways. So you have the trachea that splits into the primary bronchi, so it's still a big tube. And then the secondary bronchi, those are still big tubes. And because they are large tubes or large airways, you're going to hear a louder sound. Okay, so that's bronchiovesicular or bronchiovesicular. Then as you move lateral, farther away from these big pipes like the trachea, the primary and secondary bronchi, and now you're getting into the more terminal ends. Okay, the tubes are smaller, so the sound isn't as loud. So that's called vesicular. And that's all the V's that you see there, vesicular. Okay, so it's a soft sound, very low pitched. Okay, heard on the more distal periphery aspect of the lungs. All right, so what you do in an ideal, perfect auscultation situation, you do the full shebang. Okay, you place the stethoscope high on the chest, so above the clavicle, and that would be position 1. And your patient instructions are, every time I contact you with this stethoscope, and I usually show them contact with this thing, just want you to take a breath in like this, and then you demonstrate it. Okay, take a breath in, breath out. All right, so once they're done, then you move it over to the other side. Same spot, just on the other side, above the clavicle. All right, then you move down. And again, once you make contact, they're going to breathe, doing the best you can to go in the intercostal space, because sounds go better through soft tissue than through bone. Okay, then you move to the right side in position 2. Then you go down to position 3 and over to position 3, down, over, down, over. Okay, so that's the dance. Okay, so one more time. Above the clavicle, contact, they take a breath, move over. So 1 to 1, and then 2, 2, 3, 3, 4, 4, 5, 5. All right. And because of your location, you're going to get more of a bronchiovesicular sound. And again, you want to be in the space, the intercostal space. Okay, on your reading right there, the posterior thorax, you're going to contact up high. Okay, so above the scapula, okay, almost on that trapezius area right there. So that would be 1, 1, 2, 2, 3, 3, 4, 4, 5, 5, 6, 6, 7, 7, then 8, 8, 9, 9. All right. So again, that's in an ideal situation. Now your shortcuts are you pick one spot in the upper lung area. Okay, so you breathe in, pick one spot, and then same on the other side. So 1, 1, and then you pick one spot in the mid, 2, 2, one spot in the lower, 3, 3, and then one spot in the periphery, okay, 4, 4. Okay, this one's showing you making 18 contacts with the patient, and you can do it in as little as half that, as 8. All right, so it's a little shortcut. You want to make sure that you do get the lower corners of the lung field, because if the lung is going to fill up with fluid, just like a cup, it's going to fill up bottom to top. Okay, and so it's easy to miss those corners. So make sure you get way out there to that distal lung field. All right, every time you make contact with the patient, they are to take a breath in. Okay, that's your instructions to them on the anterior chest and the posterior chest. Okay, some abnormal lung sounds would be crackles, bronchi, wheezing, and friction rub. Okay, crackles is a type of popping, crackling sound, and that would indicate pneumonia, pulmonary edema, or pulmonary fibrosis. Okay, if it's bronchi, that's more of a rumbling sound when they breathe out. A rumbling sound on expiration is bronchi. Okay, think pneumonia, emphysema, bronchitis, or bronchiectasis. Wheezing, a high-pitched musical type sound. It's almost like it's whistling during both inspiration and expiration. Okay, this can indicate a foreign body, something that's stuck in their throat or the lung, emphysema or asthma. Okay. Pleural friction rub on your lung field, you have the parietal pleura and the visceral pleura. The visceral pleura actually touches the lung. The parietal pleura it does not actually physically touch the lung because there's a space, right, that pleural space that has some fluid in it. That space, that pleural area can get inflamed. So you have more fluid that should be there in that pleural cavity. And what that does is it creates a certain sound that they call friction rub. Okay, a dry, grated sound on both inspiration and expiration. Think pleurisy, or a type of pleuritis, inflammation of the pleura, pneumonia, or a pleural infarct, such as a pneumothorax. Okay, so that would be friction rub. All right, any questions on any of that? All right, let me do another screen share with you. This will be that second handout. Well, so what I posted, was that the same thing twice, or the two different documents? I think it was the same thing twice. Let me read the chat here. Oh yeah, okay, so no, it was two different ones. And one had more pages. Oh, maybe I didn't scroll down. All right, let me get back to it. one second, I'm almost there. Okay, I got it. So let me screen share this with you. Okay. All right. The one that has more pages. So you're looking at the blood pressure cuff there. Okay, again, this was something we would normally do together, put the blood pressure cuff on each other. Okay, so we'll just talk more of the academic side of it. So there's your cuff, and this is doing it manually. Today we do have machines and stuff that can do it for you, but you definitely want to learn manually because if you're going to be dealing with patients in clinical settings. Okay, so simply put, you just take the blood pressure. Okay, this is, it's hard to see there, but that's a patient's arm, and the cuff is on them, and there's your meter, okay, your blood pressure meter, and they're holding the bulb, okay? And then what you do is you're going to pump it up by squeezing the bulb, and by pumping it up, you're increasing the pressure to the arm, more specifically the brachial artery. Okay, and then they have the stethoscope here that they're going to place over the brachial artery, and you're going to be watching your meter there. And kind of as a quick version, you want to pump it up to about 220. Okay, there is a formula on how high you're supposed to pump it up to. No one sits there and it takes 10 minutes to plug these variables into the formula. You just pump it up. Okay, so pump it up to about 220. Keep in mind, most people's blood pressure, if it's normal, is like 120, 130, 130 milligrams or millimeters of mercury, right? 130. And you just pumped it up to 220. Of course, you're going to occlude the blood vessel. All right, so you're pumping it up enough to occlude the brachial artery, to completely pinch it off. Okay, and that takes a certain amount of pressure. So roughly you're pumping up to about 220, and then you're going to slowly release it. You slowly release the valve, and you have to go slow. And because you're releasing the pressure, you're going to see the pressure fall, the gauge fall. So it'll go from 220 to 200 to 180. Now you need to be listening to the artery. Okay, now what you're going to be listening for is Korsakoff sound. All right, so Korsakoff sound is the sound that it makes when you start to get turbulent flow. Okay, and it sounds, it's a dripping sound. It goes bloop. All right, so if you completely occlude the brachial artery, you hear nothing. When you release the pressure, this tube starts to open up. You're unkinking it. It's not kinked anymore. And because you're doing that gradually, you're going to start to hear the introduction of blood into the tube. That's Korsakoff sound. So the first sound you hear sounds like it goes bloop. When you hear that sound, you record your findings. So you're looking at the meter. Okay, you're looking at your blood pressure meter there. And you should hear it, if it's normal average, around 120. So the needle is right over 120 and you hear a bloop. So now you know systolic. Okay, so the first sound you hear is systolic. Okay, and that's the top number, right? So remember, it's systolic over diastolic. So in this example here, this person, let's just say this is their blood pressure. So 200 over 98, like that's high if that was their blood pressure. So 200 is in the numerator, 98 is in the denominator. Okay, 200 is systolic, or the first sound that you hear, the first quarter cough sound. The last sound that you hear is diastolic, and that goes on the bottom of your fraction. That goes in the denominator. So in this example, if this is the person's reading, theirs is 200 over 98, which is high blood pressure, by the way. So that would be systolic over diastolic. If it's normal or normal average, it would be like 120 over 80. All right, so you're releasing the pressure, looking at your meter. The first sound that you hear, that first turbulent sound, bloop, and the needle is over 120, so then you record that, 120. You're still releasing the pressure. Now what happens is, as you're releasing the pressure, you're unkinking the tube. So the tube, the brachial artery is getting bigger, which means blood flow is going in faster. So you're going to hear a bloop, 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 and then the last sound that you hear, that's diastolic. And it does sound like that. It's a dripping sound. It goes bloop, 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 bloop. And then you don't hear it anymore. So you look at your meter. When the meter is over a number that you last heard the sound, which will likely be around 80 if it's normal average, then you record that. So the first sound you hear, systolic. The last blooping, dripping quarter cough sound that you hear, diastolic. So there's your systolic over diastolic. Okay, so ideal would be 120 over 80. Okay, and I want you to know these values. At 140 over 90, all right, at 140 over 90 or higher, you're waving a red flag. Now they're getting into hypertension. All right, so you can go as low as 100 over 60. That's low blood pressure. For some people, that's okay. For other people, that low of pressure is too low. And then they have orthostatic hypotension stuff to deal with. Okay, but the low end would be 100 over 60. Normal average 120 over 80. Up to 139 over 89. So there's your range. 100 over 60 to 139 over 89. You have normal, low normal, high normal. Now, if I had a person that was 139 over 89, okay, even though that's high normal, we're still talking and we're still monitoring, okay? However, once you hit 140 over 90 and up, now you're waving your red flag. You're telling your patient you have high blood pressure and we should dive in to figure this out. Okay, typically diet and lifestyle changes help, backing off on salt, for example, because the more salt you consume, the more fluid you retain, and the more fluid and the more salt, then the pump has to work harder to push that around. So your blood pressure can go up just from that. Okay, that just as an easy example. Now there's a million things that can cause high blood pressure. Viscosity of blood, more dangerous things like ventricular problems, peripheral artery disease, and so forth. Okay. But once you see high blood pressure, it does warrant further investigating to figure out why this person has high blood pressure. Okay, on the stethoscope, you have this thing called a bell and a diaphragm. Let me see, this doesn't really show a good picture of that. So the bell is the smaller diameter part of the stethoscope, and the diaphragm is the larger diameter. Okay, so like what you're seeing here, there's the diameter. Okay, and when you're holding a stethoscope, most are designed to have the bell and the diaphragm together. And just by looking at it, it's the bigger circle is the diaphragm, the smaller circle is the bell. And what they have to do with is picking up on different sounds. So the bell, picks up on certain pitches, and that's how they describe the sounds, okay, a certain pitch, and the diaphragm picks up on a certain pitch. Okay, the bell part of the stethoscope that you put over the brachial artery is known to pick up on low pitch sounds, so it's heard better with the bell. The diaphragm on the stethoscope is designed to pick up on high pitched sounds. However, in real life, you know, if you talk to enough practitioners, it kind of doesn't matter, and most people default with the diaphragm anyway, okay? However, you can split hairs and do the bell over your low pitch sounds and the diaphragm over the high pitch sounds. Okay, the other thing to be concerned about with blood pressure is if the person's right versus left arm and blood pressure is 10 millimeters of mercury of pressure or greater. So you would take blood pressure on their left arm, and let's say you got 120 over 80. Then you would take blood pressure on their right arm, and let's say you got 140 over 95. That is greater than 10 millimeters of mercury difference in pressure. So therefore, something's going on, because you shouldn't see a difference that high. So your general rule is if you're taking blood pressure on both arms, yes, there's going to probably be a difference in pressure, but it should not exceed 10 millimeters of mercury difference. Okay. If you get a big difference, right versus left arm, something's going on. Warrants further investigating. Okay. So that's all I have for today for auscultating. Okay, any questions or anything? Okay, next week for lab, we're going to do renal urine analysis stuff. So we'll go over UAs and you know, a few other things that will pertain to liver, renal, gastrointestinal, and that will be urine analysis and some blood chemistry stuff, okay, for next week.